Lecture 11, Bone Markings, Articulations, and Axial Skeleton. In this lecture, we're going to take our anatomical tour through the skeletal system. Before we can discuss the specific anatomy of the skeletal system, however, we need to examine the markings that we find on bones and the ways that bones are connected to one another via articulations and joints. First, the skeletal system is composed of over 200 bones with two main divisions. The axial skeleton, which is going to form the bones of the skull, thorax, and vertebral column, and the longitudinal axis of the body. Then there is the appendicular skeleton, or the appendages. These are the bones of the limbs and girdles, both the pectoral/shoulder girdle as well as the hip girdle, and the bones that attach them to the axial skeleton. There are different associated cartilages and ligaments and other connective tissues that keep the skeleton together. Here we can see the axial skeleton and the appendicular skeleton organized. Just to review, the functions of the skeletal system are to provide structural support, to store minerals, primarily calcium, and lipids, produce blood cells, protection, and then of course movement or leverage. Now there are many surface markings on bones. There are external and sometimes internal features that tell us more about the attachments of muscles or ligaments, where certain structures might reside, or where blood vessels and nerves pass through. Now there are two major types of bone features. They are elevations or projections, things that stick out, or depressions, grooves, or tunnels, things that fold in or create a hole. Typically, elevations and projections are tendon and ligament attachment sites, and they are found at joints where adjacent bones articulate, whereas depressions, grooves, or tunnels are typically sites for blood vessels or nerves to lie alongside or penetrate bone. There are many different types of markings. I would be able to give an example of each one as we go through. Surface markings in elevation and projections would be a process, tubercle, tuberosity, trochlea, or condyle. We also have trochanter, facet, crest, line, and spine. On these slides, you will see different descriptive terms for each one. We'll go through more exact examples in the pictures later on. As far as depressions and grooves go, there's a canal or medius, sinus, foramen, fissure, sulcus, and fossa. Let's take a look at some examples. Here we could see examples of first the canal or medius. The canal or medius is going to be a passageway where typically different types of nerves or blood vessels will go through. A process is going to be a bony protrusion that typically has a sharp point where there's oftentimes a ligament or tendon attachment that would go there. A foramen that we can see is going to be another site where blood vessels go through, typically smaller than a canal or medius. A fissure is going to be larger than both a foramen or a canal, and is typically a place where larger structures go through. A sinus is found only in the skull, and we have several sinuses that we will cover, and these are going to be designed to lighten the skull and provide resonance to speech. Here on a long bone, we can see a head, tubercle, tuberosity, and of course trochlea and condyles. These are all different types of projections. Head is going to be found towards the proximal end of bones. A tubercle will be a projection that sticks off and is a site of attachment for tendons. A sulcus is going to be a groove where typically blood vessels travel along. Tuberosity is another ridge similar to a tubercle that has a tendon attachment site. The diaphysis, as we can see here, is going to be the shaft of bone, as we've talked about already. Trochlea are going to be ridges on articular surfaces, as are condyles. Condyles are typically the point where these articular surfaces meet. We, of course, have a trochanter, a very large type of tubercle or tuberosity that would stick off. Again, another attachment site. We have the neck of bone, and these come in two types, the surgical neck or the anatomical neck. Typically, the surgical neck is the point of highest break, whereas the anatomical neck is at the base of the head. Another example of an articular surface is found here at the bottom is a facet. A facet is going to be a smoother surface than a trochlea, and again, allow for articulation. Here in the hip bones, we can see a good example of a crest in the iliac crest that is a proper ridge that sticks up as another attachment site. We have a smooth surface of a fossa. This is typically where a muscle or nerve or organ will lay. We have a line, which will be a hard ridge, a spine, which will be a sharp projection, and a ramus, which is an arm-like bend in the bone. Now, looking at joints or articulations, articulations are where two or more bones will connect to one another. This is an articulation, where they interconnect, much how gears interconnect in any sort of machine. They are the only points at which movement of bones can occur. Joints allow for mobility while preserving bone strength, and the amount of movement at a given joint is allowed is determined by the anatomical structure of the joint. When looking at the functional classifications of joints, we have three types: a synarthrosis, an amphiarthrosis, and a diarthrosis. Synarthrosis are immovable articulations. They are fused together, so no movement is allowed, and these are extremely strong. An amphiarthrosis is a somewhat movable articulation. They're much stronger than diarthrosis, but they are not as strong as synarthrosis. The articulating bones are typically connected by collagen fibers or cartilage. Diarthrosis are going to be our freely movable articulation joints, and they're typically ball and socket joints. Looking at the different immovable joints of the synarthrosis, we have the sutures, gomphosis, synchondrosis, and synostis. Sutures are the joints that are found in the skull, and they are bones that are interlocked and interwoven together. Gomphosis are going to be the joints of the teeth, the periodontal ligaments of the teeth, where the roots of the actual tooth connect directly into the mandible and maxillary bones of the skull. The synchondrosis is going to be the joint within the epiphysis of the bone. This binds the diaphysis to the epiphysis. And then we have the synostis. This is a joint between two fused bones. The best examples we have of these are the fusion between the three coxal bones and the fusion of the frontal bones during early development. Here we can see examples of the sutures of the coronal, squamous, and lambdoid sutures of the skull, where the skulls will fuse following birth. Gomphosis are going to be examples of where the teeth insert directly into the maxillary bone and mandible bone at the alveolar process. We have a synostis. A synostis is going to be the complete fusion. In the fetal skull, the frontal bone is actually two pieces, but then it begins to actually fuse together following birth. Now, looking at amphiarthrosis, these are slightly movable joints, so they allow for a minor degree of motion and have greater strength than a diarthrosis. We have two types, a syndesmosis and a symphysis. Syndesmosis are where ligaments that connect two bones are present but limit their motion. These are found between the radius and ulna, and then between the tibia and fibula. The symphysis have bones that are separated by a wedge or pad of fibrocartilage. These are found between the pubic bones or of the two coxal bones. We also see a symphysis, similar structure in between the vertebrae. Here's an example of a syndesmosis. It's found in the interosseous membrane connecting the radius and ulna. It's also found in the lower legs of the tibia and fibula. Here's an example of the symphysis. We have the pubic symphysis that will separate the two coxal bones and is entirely designed to actually help with compression. The final joint is called this diarthrosis. These are freely movable joints. They're also called synovial joints, and they are typically found at the ends of long bones. We have the shoulder joint and the hip joint, or your ball and socket joints, and then hinge joints in the elbow and knee joints. Synovial joints all have 6 basic characteristics that they have in common. The first is a joint capsule. The joint capsule surrounds the entire diarthrosis joint. Next is the presence of articular cartilages. These articular cartilages are going to be found at the ends of each bones and help to prevent excessive friction. There's a joint cavity that is filled with synovial fluid. The synovial fluid itself is going to allow for the movement of bones next to each other, again helping with friction. Then there's a synovial membrane where the synovial fluid is produced. Finally, there are accessory structures as well as sensory nerves and blood vessels. The accessory structures consist of different cartilage, ligaments, tendons, and bursa sacs. Here we can see a general synovial joint structure. Note the joint capsule around the outside of it, and then on the inside of this joint capsule is going to be the synovial membrane. The synovial membrane will be where the synovial fluid is secreted into the joint cavity. Then, covering the surface of each bone is going to be an articular cartilage surface. This articular cartilage surface is going to allow for more gliding of bone as opposed to grinding. Now, the function of synovial fluid is to lubricate the surfaces of the articular cartilage and reduce friction. It also nourishes the chondrocytes of the articular surface by entering and exiting those cartilages due to the forces acting on the joint. This means movement helps nourish the bones. It also, and finally, acts as a shock absorber. Accessory structures of synovial joints include menisci, ligaments, tendons, and bursa sacs. Menisci are going to be different fibrocartilage discs that will actually be placed in between the bones, as can be seen here. They allow for greater overall compressive forces and help to try to stabilize the bone a bit more. We can see the different ligaments that are going to support the bone structure. In this example, we have the patellar ligament holding the patella in place and allowing for proper tracking. We have tendons that will attach different bones to muscle tissue and are continuous with each other. Then we have bursa. Bursa are going to be connective tissue sacs that surround tendons and ligaments and help to prevent excess friction or rubbing. Bursa can of course become inflamed over time, and we know this as bursitis. So just to review, we have the different functional categories of synarthrosis, amphiarthrosis, and diarthrosis joints. The synarthrosis consists of fibrous or sutures, gomphosis, and then we have the cartilaginous or synchondrosis, and then the bony synostis. Amphiarthrosis consists of the fibrous syndesmosis or the cartilaginous symphysis, and diarthrosis are synovial joints. Now we'll be starting our journey through the axial skeleton. This will be covered a great deal more in lab, but I'll review some of the bones here and give a few points on each one of the structures, either the bones or on some of the landmarks that we'll be covering. We'll be starting first with the axial skeleton. The axial skeleton consists of the skull, vertebral column, and rib cage. The skull consists of the face, cranium, and associated bones. The face itself has 14 individual bones, the cranium 8, and other 7 bones that are associated with the skull. During fetal development, we have the bone that's separated more apart and connected by different fontanelles. A fontanelle is going to be a soft spot of cartilage in the fetal skull. This allows the child's head to flex more specifically than anything during birth. Over time, most of the cartilage disappears, and this leaves behind sutures. There are going to be 4 major fontanelles on the fetal skull. The first is the anterior fontanelle. It is the largest and bounded by the 2 frontal bones and the 2 parietal bones. The posterior fontanelle, seen towards the back, is going to be bounded by the occipital and parietal bones. The sphenoidal fontanelle is going to be on the lateral side of the head. It's bounded by the frontal, parietal, and temporal and greater wing of the sphenoid bone. In adults, the sphenoidal fontanelle area is known as the pterion and is considered the weakest part of the skull and more easily fractured than any other part. Finally, we have the mastoid fontanelle. This is bounded by the parietal, occipital, and temporal bones. In adults, it's called by some surgeons the Mercedes point because of how it appears like the Mercedes symbol. It's used by surgeons to orient themselves. As we age, the fontanelles will actually fuse to form sutures. Here we have some of the sutures listed. The lambdoid suture will actually be in the back, separating the occipital bone from the parietal bones. The sagittal suture are going to separate the 2 halves of the parietal bone from right from left, and we have the coronal suture that will separate the frontal bone from the parietal bones. Here we have the major bones of the skull. The nasal bones will make up the top ridge of the nose. The lacrimal bones are going to make up the tear duct area of the inner side of either eye and occipital region. The palatine bone is going to be your palate, and we'll be covering that in greater depth later on so you can see a better picture, but it will make up the posterior aspect of the front jaw. Then we have the zygomatic bone, which will make up your cheekbones, the maxilla, which will be the top of the jaw, the nasal conchae, which are going to be part of the zygomatic, the maxilla, and the ethmoid bones. And these are going to be the ridges inside your nose that help to make air more turbulent. Other bones here we have are the vomer. The vomer is going to be the lower portion of your nasal septum. The mandible, which will be your lower jaw. Of the cranial bones, we have the parietal bones that will make up either side, the frontal bone, which makes up the front aspect of your skull, the sphenoid bone, which will make up a lot of the interior of your skull, and the ethmoid bone, which will make up the back portion of your upper nose, as well as some of the anterior portion of your cranial cavity. On the posterior aspect, we have, of course, the occipital bone, which is going to be the back of your skull, and the temporal bones on either side, which will be where the ears would be on your skull. Here we can see other views and separations of the bones as described. We will start first with the frontal bone, which forms the forehead and roof of the orbits of the eyes. It articulates with the parietal bones via the frontal suture, and originally is formed from two separate bones. These two bones fuse completely by about 8 years old. We can see some of the major structures here. First will be the supraorbital foramen. It's a passage for the supraorbital nerve, artery, and vein. It is on either side of the arches. The superciliary arches are also known as the supraorbital ridge or brow ridge. This provides strength to the frontal bone. One of the last traits to be lost in the development of Homo sapiens due to anterior enlargement of the frontal cavity to contain a larger frontal lobe. They tend to be shallower and more gracile in females compared to males. The supraorbital margin is the arched ridge of bone, forming a superior orbit of the eye, and it can be used to determine sex from skull bones. Thick and rounded in males, narrow and sharp in females. The glabella is going to be in between these. It is the center of the forehead between the superciliary arches and nasal bones. It is a frequent site for Botox treatment to eliminate those, quote, glabellar lines. It serves as the origin for the corrugator superciliae muscles, or the muscles that move your eyebrows. The frontal sinus is a small mucosa-lined and air-filled space in the frontal bone just behind the superciliary arches. A bony duct connects it to the nasal cavity. It produces large amounts of mucus for the nasal cavity. The sinus and duct sometimes becomes clogged or infected. We know this as a sinus infection. The final structure in the frontal bone is the anterior cranial fossa. This is a shallow depression that houses the frontal lobes of the brain. The next bone is the temporal bone. Temporal bones are a pair of bones located at the temple or lateral aspect of the cranium. They support and protect the brain, contribute to the zygomatic arch or cheekbone, and form the only articulations with the mandible, and protect the inner ear. Some of the landmarks to note here are first, the external and internal acoustic medius. This is simply your ear canal or ear hole that would feed into the inner ear. We have the mastoid process. The mastoid process is where several muscles attach, including the sternocleidomastoid and digrastic muscles. The mandibular fossa is going to be where the mandibular condyle articulates directly. Then we have the styloid process, which is a long, sharp projection where several muscles and ligaments attach, including the stylohyoid muscle. Here we can see another view of the external acoustic medius on the temporal bone, as well as the mastoid process and styloid process. On the underside of the skull, we can see some of the other structures on the temporal bone, namely the carotid canals. The carotid canals are going to be a passageway for the carotid artery. The internal opening is called the foramen lacrium. The next bones we'll talk about will be the parietal bones and then the occipital bones. The parietal bones have no landmarks we need to know on them. They are a pair of bones on either side of the skull that are on the side of the sagittal suture that connects them. The occipital bone is a thick, strong cranial bone at the posterior inferior aspect of the skull. It does have a few landmarks we need to know. Some of the landmarks to know on the occipital bone are the foramen magnum. It is a large, very obvious opening, and this is the passage for the spinal cord. Next to the foramen magnum are going to be the occipital condyles. This is where the skull articulates with the first vertebrae, C1, called the atlas of the vertebral column. Moving back, we have the external occipital protuberance. It's less pronounced in females and provides a strong support and protection for the back of the skull. We also have the jugular foramen. The jugular foramen are large openings for the jugular vein. Both temporal and occipital bones contribute to form this opening where the jugular veins enter. Finally, we have the posterior cranial fossa, the most inferior portion of the skull. It is a shallow depression that houses the cerebellum, medulla, and pons. Here we can see on the interior aspect of the skull some of the other bone structures that we'll be noting. We can see some of the internal structures of the temporal bone, as well as the occipital bone, sphenoid bone, ethmoid, and frontal bone, as they form the rest of the skull.